Intraamniotic inflammation or intraamniotic infection. And this is mostly associated with the administration of an epidural, because an epidural can induce a fever in 10 to 20% of mothers. But by far, the most common cause of this syndrome, clinical choriamnionitis at term, is intraamniotic. Now, where do microorganisms come from? All patients have microorganisms in the lower genital tract. These microorganisms may gain access to the amniotic cavity via ascending infection. And we know this because we have compared the microorganisms in the amniotic cavity with vaginal swabs and the microbiome, and we have been able to identify that in the overwhelming number of cases, the organisms in the amniotic cavity are also present in the vagina using sequencing techniques. It's also important to realize that the duration of labor, per se increases the risk of microbial invasion of the amniotic cavity. At term, without labor, the frequency of microbial invasion is 1%. But when there are uterine contractions, there is a suction-like effect, and then microorganisms may gain access, even in the absence of maternal fever. And the frequency of bacteria in patients who are spontaneous labor at term is 19%. Now, the status of membranes matter a great deal because the frequency of bacteria in patients who have clinical choriamnionitis is 78% of the membranes are intact, but almost 80% of the presence of rupture membrane. What are the microorganisms present in the amniotic cavity in patients with clinical choriamnionitis at term? The most common microorganisms are Ureaplasma species, followed by Gardnerella vaginalis and Streptococcus agalactiae or GBS. Now, organisms in the amniotic cavity elicit an inflammatory response. The inflammatory response can be on the maternal side or can be on the fetus. For example, bacteria in the amniotic cavity can induce a fetal inflammatory response on the production of cytokines. And this, if the cytokines go into maternal circulation, this will elicit a fever, because the fever is induced by the brain. And this fever will be a sign of maternal systemic inflammation. In addition, the organisms can gain access to the fetus, and microbial products will induce a fetal inflammatory response that we call it a syndrome because it may involve several organ systems. For example, it can induce neuroinflammation, and this is the reason why infants born with clinical choriamnionitis have an odds ratio of 9 for cerebral palsy. What are the fetal heart rate changes in clinical choriamnionitis? The most common is the presence of a fetal tachycardia. Here you can see 160, the fetal heart rate is above 180. Clearly, fetal tachycardia with loss of variability. In addition, clinical choriamnionitis may be associated with repeated late decelerations. Here are the contractions, and you can see repeated late decelerations after the apex of the contraction. This is not due to uterine placental insufficiency. In most cases, with clinical choriamnionitis at term, have a normal umbilical artery pH. If you have clinical choriamnionitis with absence of variability, you need to consider that this is a sign that there is fetal inflammation. In addition to the fetal heart rate changes, another observation that is important is a decrease in uterine contractility and decrease in the total activity expressing Montevideo units. So how do we know that? Because a group of investigators in the United States put intrauterine catheter, and here is a decrease in uterine contractility 2 hours after the onset of maternal fever. This is important because it explains 2 complications of clinical choriamnionitis. The first one is that there is more frequently failure to progress in labor, and the second is that patients who have clinical choriamnionitis have an increased risk to uterine atomy after the delivery of the baby. The differential diagnosis includes intra-amniotic infection, but in addition, there is a clinical enigma in diagnosed patients who have a maternal fever and other signs of inflammation but do not have microorganisms in the amniotic cavity. Frequently, this is due to the fact that patients have an epidurals can induce neuroinflammation in the mother. This neuroinflammatory process, in the absence of intra-amniotic inflammation, can induce a fever. Here is the maternal temperature, 4 to 6 hours. This is non-epidural patients who have a stable temperature. And here, after an epidural insertion, you see the development of an increased maternal temperature and also the development of fever. The management of clinical choriamnionitis is straightforward. First is antibiotic administration. Second, we need to consider antipyretics, and then the induction or augmentation later. The latter to address the problem of uterine hypodynamia or decreased uterine contractility. In terms of antibiotic administration, the rationale for antibiotic administration prior to delivery is a randomized clinical trial published more than 30 years ago, in which 48 patients were randomized with clinical choriamnionitis near term were randomized to intrapartum administration or postpartum administration. Patients were given ampicillin, gentamicin, and clindamycin if there was a cesarean section, and antibiotics were continued until the patient was defibrilled. The results of this study indicated that patients who have intrapartum administration of antibiotics had no evidence of neonatal sepsis, no evidence of pneumonia, and had a shorter hospital stay. This single trial, with only 48 patients, has not been replicated and has changed the practice of obstetrics by requiring the administration of antibiotics in the intrapartum period, not to wait until delivery. Antibiotics should be given then in the intrapartum period. What about the antimicrobial agents? All professional societies, the American College of OBGYN, WHO, recommends the use of ampicillin and gentamicin. And at the time of cesarean delivery, to add clindamycin after clamping of the umbilical cord. I think it's important that I remind you that the most common organisms are genital mycoplasma and specifically Ureaplasma ureolytica. And these organisms, because they do not have a cell wall, are not affected by ampicillin and cephalosporin. So macrolides are effective. These include erythromycin, clarithromycin, and azithromycin. They have a good activity against ureaplasma. The drug of choice is clarithromycin because it has a higher transplacental passage than other macrolide antibiotics, such as erythromycin. Antipyretics, if the patient has a sustained fever, the fever is very high, one of the alternatives is considered acetaminophen. The dose 325 to 650 milligrams every 4 to 6 hours. This generally results in a mean decrease in temperature of 1.2, generally improves fetal outbreak patterns. And here is a patient with fetal tachycardia. After the administration of antipyretics, you see an improved fetal outbreak. In conclusion, clinical choriamnionitis is a heterogeneous condition, is the most common infection-related complication in labor and delivery units. 65% of patients diagnosed with clinical choriamnionitis have proven intraamniotic infection. The frequency of the infection is higher when the membranes are ruptured than when they are intact. The most common organism is Ureaplasma ureolytica, and antimicrobial agents need to be administered intrapartum. We need to consider the use of macrolides, given that these are the most frequent organisms in amniotic fluid. Thank you very much.